Hello, and welcome to today's Gairdner National Lecture. I'm Janet Rossand, President and Scientific Director of the Gairdner Foundation. At Gairdner, we're best known for the prestigious Canada Gairdner Awards, which we've been awarding for over 60 years. 395 awards have been made, 97 laureates have gone on to receive the Nobel Prize, including this year with Dr. David Julius. We're delighted to be able to bring our laureates to speak at universities across the country, where they inspire us all to greater heights in our own research. Our laureates this year have made discoveries that have had an impact on millions of lives around the world, from diabetes to breast and ovarian cancer to zoonotic diseases. The reach of their research is truly global. Your Gairdner National Lecture today is part of a series of virtual events happening from coast to coast as part of Gairdner Science Week. Please visit our website at gairdner.org or check out our social channels at Gairdner Awards to see the full schedule and register to be part of an exciting week of outstanding science. I'd like to thank our sponsors, the Government of Canada, CIHR, the governments of Quebec and Alberta, and the Globe and Mail for their ongoing support of our programs, as well as other sponsors listed on our website. Their support makes events like this possible. I hope you enjoyed today's talk and that you'll join us for all the other fantastic programming that Gairdner Science Week has to offer. Thanks and enjoy.
My name is Arnold Neymark, and I'm pleased on behalf of the University of Manitoba and its Centre for the Advancement of Medicine to introduce the 2021 Canada Gairdner Wightman Award laureate, Elizabeth Eisenhauer. In the conferring of the award, Dr. Eisenhauer was cited for her work in the investigation of new cancer drugs and how they are used, for leading changes in the conduct of cancer trials, and for establishing new standards of cancer treatment that have benefited patients around the world. In addition to her scientific achievements, Dr. Eisenhauer has undertaken important and challenging leadership roles in prestigious Canadian and international bodies devoted to the advancement of knowledge and its application to the treatment of cancer. She's now Professor Emerita at Queen's University and the Innovation Lead at the Kingston Health Sciences Center. At the national level, the distinctions that have marked Dr. Eisenhauer's outstanding career include the appointment as an Officer of the Order of Canada and her election as a Fellow of the Royal Society. The Wightman Award recognizes a Canadian health researcher who has demonstrated extraordinary leadership paired with exceptional science, attributes so clearly exemplified by Elizabeth Eisenhauer. We are unfortunate indeed that she is able to be here virtually to share with us her decades-long experience with cancer clinical trials and why, as her lecture title suggests, we still have miles to go before we sleep. I should just mention that a slide will appear in due course indicating how you can submit questions through the Slido system for her attention. Dr. Eisenhauer, welcome.
Thank you very much. It is my great pleasure to be here, albeit virtually. I wish I were there in person because the West holds a special place in my heart. I think I can just start sharing my slides now, and we'll do so. And I will expect that someone will say something if they're not visible. So as I said, it is a great pleasure to be here, a great honor for me and for all of the people I've worked with for 35 or more years in clinical trials to be the recipient of the Canada Gairdner Wightman Award. As Dr. Neymark mentioned, I'm going to be discussing some personal reflections of 35 years in cancer research, showing you, I hope, how we have improved cancer outcomes, but leaving you with some ideas about where we need to go next. And this is a bit of an outline of what I will touch on. My work started in 1982, and it's important to understand the context of that time. giving you a little bit of a history of where cancer treatment and was prior to that, and how over the 80s, 90s, and into the 21st century, we have changed our understanding of cancer and how it's led to new treatments. So 1982, well, lots happening then. The patriation of the Canadian Constitution from Britain, signed by Her Majesty the Queen and Pierre Elliott Trudeau, April 1982. The desktop computer, the machine of the year. A new disease, the acquired immunodeficiency syndrome, was gaining traction and publication in the research and scientific literature. Michael Jackson releasing his Thriller album. And a young man in New York City, clearly already thinking about things presidential, sadly, perhaps. Also in 1982, I became the mother to my second daughter, Nicole, in March of that year. Here she is with her older sister, Danielle. But the story I'm about to tell starts long before that. Cancer, of course, has been with us for millennia, and there were limited benefits from any sort of treatment until the late 19th and early 20th century, when surgery was made possible by the discovery of anesthesia and sterile techniques. Radiation was discovered about that time as well, but it took another half century before it could be used therapeutically. And many patients died within a few months to years. Now in Canada in 1947, the Canadian Cancer Society created the National Cancer Institute of Canada to undertake research in cancer and its treatment. And at that time, an important number to remember is that 5-year survival rates for all cancer combined was only 33%. In the subsequent decades, a lot began to change. Therapeutic radiation became possible once we understood better physics, radiation dosing, and how to provide it safely. New imaging technologies such as CT scanners started to be deployed, and that made it possible to more accurately stage cancer and plan treatment. And finally, the first so-called chemotherapy drugs had been discovered, many through the US National Cancer Institute screening program, and I've listed a few there. By 1987, which actually was the first year that you can go back to online and get statistics, you can see on the right of the screen the 5-year net survival rates for the common solid tumors and leukemia were uniformly below 50%, with the only exception being breast cancer. In the 1980s, there were big changes in cancer research afoot. And this is what I started, or when I started my work. Firstly, in the laboratory, new technologies and techniques and cancer models became available, and these were used to begin to unmask those fundamental biological changes in cancer cells that foreshadowed where new treatment would go 2 decades later. In the clinic, Canada, like many other nations, began to think about how clinical trials could be undertaken by creating networks that would undertake academic-driven research studies to accelerate the pace of development of new and effective cancer treatments. And in Canada, the story was the same. Here, with funds from the Canadian Cancer Society, the National Cancer Institute of Canada launched a clinical trials group, so-called NCIC-CTG, to coordinate and conduct cooperative clinical trials that had a goal of improving cancer outcomes. Now, the first director of the NCIC-CTG was Dr. Joseph Pater, who's an oncologist and epidemiologist at Queen's University, and that is actually why the head office of the NCIC-CTG was moved from Toronto to Queen's. Rumor has it was Joe's wife who didn't want to move to Toronto. And in 1982, I was invited to join the NCIC-CTG as the first director of the Investigational New Drug Program. And here we are outside our first office on the university campus, an old red brick building. And you can see the shoulder pads tell you what decade we're in quite clearly. The mission of the NCIC-CTG then, as it is now, is to develop and conduct clinical trials aimed at improving the treatment and prevention of cancer with the goal of reducing morbidity, and mortality. To do this, the group required 3 interlocking components. Firstly, scientific and clinical leaders from across the country needed to decide to work together to prioritize questions worthy of study. Secondly, cancer centers and hospitals where cancer patients were treated needed to agree to become part of that network so that their patients could be enrolled on the trials. And finally, a central statistical and coordination center needed to be put in place where the know-how and the supports were organized to actually appropriately conduct and design studies. And all 3 of these together is what the NCI-CCTG was and is. And I note that in 2016, this group was renamed the Canadian Cancer Trials Group, and that's how I will refer to it by and large through the rest of my talk. So let's talk a little bit about the IND program and its beginnings. In the 70s and 80s, interestingly, most new cancer drugs were actually identified and developed by the US National Cancer Institute Developmental Therapeutics Program. Seemingly ironically, compared to today, pharmaceutical industry was not interested in cancer as a therapeutic area. It was seen as too high risk with too low a return on investment. Canadian investigators and their patients did want an opportunity to be part of these early phase trials, which were awarded based on letters of intent submitted to the NCI in the States. In 1981, the NCI-CCTG put together an investigational new drug committee that was chaired by Brian Weinerman, who was an oncologist in Winnipeg at that time. And it was agreed that the best way to get our hands on drugs coming from the NCI in the States was to appoint an oncologist as part of the Central Statistical Office who would help to identify drugs in the pipeline so we could become more competitive. And with that, the IND program was founded, and I was hired to be that junior oncologist. So what were my qualifications at that time to lead a national cancer treatment program? And they were pretty limited. I had completed training in hematology. Oncology was not yet a specialty. I was once enrolled as a subject on a clinical trial, and that is a longer story to be told over a glass of wine. I played violin in the local symphony orchestra, so I did know a little bit about collaboration and teamwork, but pretty much no other specialty training except I was keen and wanted to do trials. And I would acknowledge, however, that at that time, this was such a young area in Canada. Very, very few Canadian investigators had any experience or training. So my first lesson for today is expanding your horizons to do things in which you're interested but don't yet have expertise can lead you to some challenging and interesting places. So in the early years of the IND program in the 80s, we really began by focusing on so-called phase 2 studies. These are clinical trials designed to screen new drugs for evidence of activity in cancer patients. Despite the discovery of oncogenes back in the 70s, it would be some years yet before that translated into new therapies. So most new drugs were so-called cytotoxic agents coming from the big screening platforms in the NCI US. Now, while we did have a few lemons in the first years of the program, we also had some exciting results. And I'm just going to highlight 2 here. IND 12, the 12th study we undertook, was with a new drug called CBDCA, now known as carboplatin. And we studied it in recurrent ovarian cancer, where we observed about a 30% response rate and made some recommendations about dosing that carried forward into a large randomized trial done by the NCI-CCTG that showed carboplatin in frontline therapy was a new standard to replace cisplatin, and that remains the case to this day. Now, here's an interesting Winnipeg connection. Dr. James Johnson, who's a hematologist in Winnipeg, had been studying in his research lab a rare leukemia called hairy cell leukemia, and he found that a drug called deoxycoframicin seemed to be helpful in these lab studies. So by some machinations, we managed to get a supply of the drug, got it approved by Health Canada for study, and evaluated it in patients with hairy cell leukemia across Canada. And that trial actually showed 100% response rate in patients treated, with the majority of them having complete remissions of their leukemia. And as a hematologist, I was fortunate to actually enroll the very first patient on this trial. This gentleman had the, I guess, good fortune to have been diagnosed immediately prior to the trial being opened. So I enrolled him on this phase 2 study. He was quite ill, tired. He has his marrow full of disease and a huge spleen, cartoon here. And after just 3 doses of deoxycoframicin over 3 weeks, when he came back for assessment, his spleen was no longer palpable and his marrow was returning to normal. So my second lesson is really, as you can imagine, there's nothing as an investigator more exciting than participating in research that has this kind of dramatic impact on a patient's life. And only a very few of these in a career can spur you onwards. The 1990s I call the taxane decade, and it started with a drug called Taxol. Later its generic name was changed to paclitaxel, which was an extract from the bark of the Western yew tree. Now, this was found active in the NCI screening system in the 1960s, a very complicated chemical structure that you can see here. One does wonder why a yew tree would need to make this. But nonetheless, it became interesting for clinical trials when a novel mechanism of action for paclitaxel was identified by Susan Horowitz in the 1970s. She showed that it stabilized microtubules, preventing them from coming apart at the end of cell division, locking cells into a state that culminated in cell death. So this moved into the clinic in the early 80s and had significant cardiac toxicity and significant severe hypersensitivity reactions seen in the first few patients. And in some settings, that might have been considered a death knell for this particular drug. But because already there was some activity of this agent in ovarian and breast cancer patients in those phase 1 studies, a number of maneuvers were undertaken to try to overcome those particular issues. Pre-medication with steroids and other drugs, prolonging the infusion, cardiac monitoring were all introduced. Now in Canada, we were thinking, how can we help with the development of this drug? We wanted to get our hands on it to study in ovarian cancer. So we proposed a randomized trial evaluating 2 different doses and 2 different schedules in a bifactorial design in relapsed ovarian cancer. And this was the first trial in which we had collaborated with Europeans in doing ovarian cancer research. And we found, much to our surprise in a way, that the 3-hour infusion, which was way more convenient, as you might imagine, was not only safe, it was safer than giving the 24-hour and longer infusions. It produced less myelosuppression and complications. Furthermore, it appeared to have slightly more efficacy, as did the higher dose. So higher dose 3-hour infusions, 175 over 3 hours, became the standard of care from that point onwards for all paclitaxel clinical trials. But it also led to 2 other important developments. The first was pretty obvious. Working with our European colleagues, we then designed a frontline trial in ovarian cancer, adding paclitaxel to platinum, and compared that to the standard of care. And as you can see here, this had a highly significant impact on improving overall survival, with a gain of nearly a year at the median. And this was despite the fact that patients on the standard arm were able to receive paclitaxel when they relapsed. So that too changed standard of care, and to this day, paclitaxel and carboplatin are the standard backbone of ovarian cancer treatment. But the other thing we learned was that it was not only possible, but better to be thinking about collaborating not just in our country, but with other groups with interests that were similar. So the gynecologic cancer group was created as a result of these original OV9 and OV10 studies. and now consists of 35 cooperative groups around the world, all engaged in gynecologic cancer clinical trials, including ovary, cervix, and endometrium. And periodically, and here we were at a beautiful place in Baden-Baden in 2004, periodically group members would meet to develop consensus statements about standards of care, and more importantly, highlight what are the key questions that together we should be addressing. One of the first consensus conferences was around the time OV9 was starting, and here you see me in Denmark with Martine Picard. So the third lesson I would leave you with is that collaborations, not just within borders, but across borders and oceans, not only speeds clinical research, but at least for me, created lifelong friendships. So the 90s were the decade of taxanes everywhere. With the success of Taxol in ovarian cancer, dozens of trials were ongoing in almost all solid tumors. And in addition, the first analog, a derivative of the European U, docetaxel, started phase 1 trials, and it had a bit of a theoretical advantage. Unlike Taxol, which had to be formulated in cremophore, which was thought to be the root cause of those hypersensitivity reactions, the theoretical advantage with docetaxel was it didn't have that formulation, so no pre-medication would be needed. So because of our track record in Canada with paclitaxel and OV9, we got this new agent for 5 phase 2 studies in the IND program, including one in breast cancer that Maureen Trudeau from Toronto was chairing. And by the 10th patient, we knew really 2 things with certainty. The drug was active. 7 out of those first 10 patients had dramatic, rapid partial responses to treatment. And secondly, pre-medications were needed because virtually all of them had hypersensitivity reactions. And docetaxel or Taxotere has gone on to become part of the standard of care in breast and many other diseases. By the late 90s, change was in the air. Targeted drugs were emerging. We were talking about new endpoints in trial design. And professionally, some changes were emerging in my own life. So, targeted drugs. Important to recall that all cytotoxic chemotherapy drugs do have molecular targets, whether that's DNA or the machinery of cell division. This new wave of targeted agents really focused on compounds that were targeting either signaling molecules or receptors that were thought to be the root cause of why cancer exhibited this uncontrolled growth phenotype. We expected them to be less toxic and to turn cancer into a bit of a chronic disease. Now, at that time, I was invited to a cancer drug development meeting in Amsterdam and asked to share how I thought these new agents would change how we would have to design and evaluate trials. So then, at that time, I predicted that phase 1 endpoints, which up until then had been toxicity experienced by the patient, might change to be based on optimal target inhibition. And the phase 2 endpoint, which up until then had been the observation of objective tumor regression or response, might not occur. These drugs might just cause disease to halt, and we needed other measures and randomized designs to detect them. And the third thing was biomarkers for patient selections would be important and easy because, after all, we knew what targets these drugs were going after. So targeted drugs were everywhere in the next decade, and our IND program, of course, began a number of phase 1 and 2 trials, as did many, many other research groups. And on this slide, I just make a long list of some of the targets and some of the agents we studied. I don't list all the tumor types, but suffice it to say, many of those trials were disappointing. And there were some exceptions in hematologic malignancies with bortezomib, a proteasome inhibitor, and sorafenib, a RAF inhibitor, and VEGF receptor tyrosine kinase inhibitor, which you can see there. That being said, meanwhile, in the phase 3 side of the Canadian Cancer Trials Group, we did undertake some phase 3 trials with targeted drugs, in both cases EGFR inhibitors, in colorectal and lung cancer, and both of those showed improvements in survival and led to marketing approval of those drugs worldwide. By 2005, already we were getting a sense that targeted therapeutics exhibited what you might call a mixed response. There were some striking, game-changing observations, such as imatinib in chronic myeloid leukemia. There were some perhaps less visually dramatic, but important and practice-changing results. For example, the HER2 inhibitor trastuzumab in adjuvant breast cancer. But many results from investigators around the world were negative or even worse, where on this right-hand side, you can see that the experimental arm actually does worse than the standard. So the bloom on the rose of targeted therapy was beginning to fade a bit. I think it was more like we were becoming more realistic. Not everything was going to be in imatinib and CML. And furthermore, my predictions were often wrong. We thought these would be non-toxic. Well, we were wrong. They were toxic. They caused diarrhea, skin rashes, and many other side effects. Dosing based on target inhibition was really hard to measure, and so we defaulted to toxicity anyway. We did see tumor regression with these, and in fact, in this paper that one of my fellows did with me, we actually reviewed a decade of targeted therapeutics and showed that those that were causing tumor regression at the highest rates were the same ones that were most likely to succeed in randomized phase 3 trials in improving survival. And finally, biomarkers were important, but they sure weren't as easy as we had predicted. So this is the fourth lesson. Predictions based on imperfect knowledge of biology can be wrong. And so you really have to be open-minded and focus on what you're seeing in the clinical experiments and use that to rejig your hypotheses. Now, as this lesson was unfolding, as I said, my own life was expanding a bit. I became involved in cancer research leadership at the NCIC and in teaching about clinical research in Canada, US, and Europe. And the rationale for that was, well, I really felt we needed to help give back, teaching the next generation. And here's a photo from a week-long clinical research methods course in Switzerland from the early 2000s. And furthermore, as we are funded by research organizations, we need to support and help them grow because we need to give back to them and support them in their work. And not least because this kind of engagement is fulfilling and fun. And again, many new colleagues and friends that were lifelong friendships evolved. So we're moving closer to the present. Between 2005 and 10, we continued to identify many new genetic or epigenetic targets that have been giving rise to new potential therapeutics. And the rise of the so-called precision medicine mantra evolved. Anti-angiogenesis drugs were emerging, and I was moving a bit more from research into more cancer control and policy. So I'm just going to talk about the anti-angiogenesis therapeutics. The brilliant Judah Folkman really led this field in describing the role of new blood vessel formation in promoting and sustaining tumor growth and in identifying inhibitors of this process. And expectations from this were high when one of the very first of these drugs that he'd identified, endostatin, went into clinical trials. And there were whispers in the corridors that the cure for cancer might be in sight, and we would know within a few months. Needless to say, the IND program was very engaged. We did a lot of phase 1/2 trials with inhibitors of angiogenesis, and in this particular example that I'm giving here, vascular endothelial growth factor receptor tyrosine kinase, cediranib. And those trials led to larger randomized trials in lung and ovarian cancer. Now, the lung study was negative, but the ovary study, which was a gynecologic cancer intergroup study that we designed with our colleagues in the UK, who were the lead group for that study, showed some significant improvement of this angiogenesis inhibitor in progression-free survival in ovarian cancer, but it didn't quite meet the bar for significance for overall survival, as shown here, where there's a visual improvement, but a p-value that is greater than 0.05. Nonetheless, this agent is now being explored with combinations and in other regimens in ovarian cancer. So this wave of trials of angiogenesis inhibitors was the biggest we'd ever seen. Just with one drug alone, bevacizumab, more than 1,000 trials were recorded in the clinical trials database at one point. Despite all of these studies, sad to say, inhibitors of angiogenesis have only rarely had a meaningful impact on cancer survival rates. And in part, that may be due to the fact that the models that we used to demonstrate how important angiogenesis was had extremely quick doubling times, extremely reliant on angiogenesis. And that is not generally how quickly human tumors grow. So those models were good for understanding some biology, but they were imperfect at predicting how relevant this might be to the human tumor situation. And I guess the other lesson was, when you're not seeing that a drug or drug class has very much activity, you can't just make it become active by doing thousands of trials. As I noted a moment ago, at the same time, I was becoming more involved in cancer strategy and policy. And one of the things I became involved with was the Canadian Cancer Research Alliance, which was an alliance of cancer research funding agencies that was created as part of the initiative to create a Canadian strategy for cancer control. And it was Vic Ling and Phil Branton that really got the alliance going. But I chaired it for almost a decade, between 2008 and 2017. And one of the questions we thought it was timely to ask was, how do funding agencies collaborate better and, by sharing investment in some big ticket items, actually accelerate impact? And that question led to the first Pan-Canadian Cancer Research Strategy in 2010. And in that strategy, there were 24 action items. I'm pleased to say we actually did 22 of them. But one of them explored the struggling state of academic cancer trials at that time. And that report, which had noted that the number of institutions that were willing to put patients on non-pharmaceutical firm studies was dwindling, and that we were in trouble, one of the recommendations was to create an infrastructure program for academic trials in the cancer space. And that was the Canadian Cancer Trials Network, housed at the Ontario Institute for Cancer Research and led by Janet Dancy. And since it started in 2015, funded by about 13 different funders, there's been a 200% increase in academic trial enrollment. So let's talk about the last 10 years. We're in the midst of what you might call the immune oncology revolution, and professionally, a number of things were changing in my life. So I was going to call this the immune therapy wave, but frankly, it is a tsunami. Starting with immune checkpoint inhibitors such as anti-CTLA-4 and PD-1, PD-L1 inhibitors, we've seen improvements in outcomes, particularly in melanoma, but also in other cancers. In addition, CAR T cells or engineered T cells have been shown to have activity in some hematologic malignancies, and there is a lot of research ongoing about how we can exploit this as well for solid tumors. And in the CCTG, we have done numerous clinical trials. An adjuvant lung cancer study, BR31, has completed accrual. This was a trial that I was part of the discussions to start when I was in CCTG as the acting director in 2014-15. Similarly, a trial with melanoma looking at the duration of treatment, multiple combination and translational studies. And recently, Dr. Annette Hay at Queen's has obtained funding from CFI to set up a CAR T research platform in a multi-center setting. But important to realize that this is a tsunami. As of September, a year ago, there were 4,400 clinical trials of PD-1, PD-L1 inhibitors alone. There are multiple inhibitors in the clinic at the same time. And while this is exciting, there is some concern here in my mind because those multiple inhibitors are addressing basically the same question over and over, meaning that failure might be duplicated, resources wasted, and the costs to us all increased. So important to balance exciting questions versus how unique they are. In 2012, a bit of a shift in my own life began when I attended a UICC meeting when Chris Wilde, who was the director of the International Agency for Research on Cancer in Lyon, France, said this in his discussion of what was lying ahead for cancer internationally. He said, the global cancer burden is and will become so large that we will not be able to treat our way out of the cancer problem. And as somebody who had spent her whole life in the cancer treatment space, this sort of illuminated to me the need to be thinking more broadly on a personal level. So the first thing that I did was to start to talk to colleagues about why the heck aren't we as oncologists doing more about the most preventable cause of cancers internationally, which is tobacco use. And one thing led to another, as it does sometimes, and we held a national summit at Queen's to create the first ever tobacco endgame for Canada with a goal of achieving less than 5% tobacco use by 2035 and over 41 different potential measures outlined to get there. And in 2017, the federal government adopted that as its goal in its new tobacco control strategy. So I guess lesson 5 is open your big mouth and stuff happens, but more appropriately, applying learnings from leadership and research, you can actually affect change in other areas that are important. The other thing I decided to spend some time thinking about and working on was palliative care. So oncologists, especially people from my vintage, have a lot of experience with the need for optimal palliative care. And despite this, it has been challenging to ensure that this is well integrated in cancer care and available to all patients, to say nothing of other chronic diseases. So it raised the question, are there better models of care that we could be investigating or implementing? And because my husband, a family physician who did palliative care, and my daughter, a palliative medicine specialist, shown here, sat around the dinner table with me, we had a lot of conversations about that. And again, a lot of fun. The first, hopefully not the last article I wrote with my daughter around looking at evidence and overcoming barriers to early integration of palliative care. So let's dial it back a bit and say, well, really, in the 35 or so years that I've been involved in this work, what have we achieved? So the 5-year net survival now for cancer in Canada is 63%. And if you look at those 4 solid tumors that I highlighted from at the beginning of the talk, you can see there's been substantial gains in all of them, maybe with the exception of lung cancer. And although I don't show you the mortality data, this isn't all about just earlier diagnosis and it is actually that mortality is falling for these as well. So in 35 years in cancer research, the other thing that we can look at is just how much has changed into what we're looking at therapeutically. Cytotoxics, the only thing around when I started, still here, but much less. Targeted drugs and precision medicine have kind of replaced much of that, with waves around taxanes, angiogenesis inhibitors, and immune agents. And it's interesting when I look at our prevailing theories of what was driving cancer over those same years, the kinds of agents we were studying depended on what we thought was the big thing at the root cause of cancer. So when it was all about cell division and DNA, cytotoxic chemotherapy was where we were focused. As we understood more about molecular signaling and pathways that drive cancer phenotype, targeted agents emerged. Then it was actually not about just the cancer cell, but the environment in which it was growing, the supportive cells and around the cancer, the blood vessels, and again, a new wave of treatments. And now immune oncology agents, cell therapies, the microbiome, seeing the cancer situated with a whole organism or whole person are driving how we are thinking about new cancer treatments. So what comes next? Given how successful my 1998 predictions were, I would take some of this with a grain of salt, but I think it's clear that the more we discover about cancer and biology, there will be new opportunities for therapeutics. And the impact of immune oncology is really just beginning. We also have new technologies that can identify minute amounts of cancer DNA in the blood and other markers, and it's yet to be determined how that will affect early diagnosis, monitoring, treatment, and relapse, and ultimately mortality. And large clinical trials are needed to sort that out. And finally, data. Everybody says we need to use it, and that is true. But data is only a tool to answer questions that are driven from the observations and hypotheses around us. We have mountains of it from patients, biospecimens, imaging. And through this, I hope some good questions will be answered, allowing us to predict and prognosticate better. My advice to the next generation of clinical cancer researchers is obviously to be collaborative. We get there faster when we work together. I would say also resist the push to just endlessly duplicate ongoing research. That is not creative, and it will just increase the costs overall of research. Engaging patients as partners, I haven't had much time to talk about, but it was central to what I did. And for cancer research funding agencies, investing in academic clinical research really is important. Creating the infrastructure for a healthy clinical trials community that can do trials beyond those of interest to pharma is critical. So in 35 years, there's many thanks to give, particularly the Canadian Cancer Society, to mentors, colleagues, trainees, thousands of patients, and especially to my family. Now, we are grown older for sure, grown larger, and grown up. So much has changed since I started my cancer research work in 1982. I hope you get a sense of the times I've really been privileged to live and work in. In addition to living through this time where we were part of big impacts on cancer through the trials that we did, I experienced a personal journey that wasn't really planned, and it has brought lifelong friendships, shared experiences, and meaning. Our work is far from done. Too many people are still developing, suffering with, and dying of cancer. So we have promises to keep and miles to go before we sleep. And with my very last slide, I will acknowledge that those lines are the last two of this beautiful poem by Robert Frost. Thank you for your attention.
Well, I'd certainly encourage any questions on Slido. So far, there are none. All right, one has just come in. It says, thanks for the excellent talk. Since you mentioned that there was a large amount of duplicate studies, I was curious about your thoughts on alternative target.
Alternative target, I don't quite understand. I mean, one of the big changes in the fact that pharma has become interested in cancer as a space to do investigation is that everyone is chasing the same targets. and developing drugs which might not be direct analogs of each other, but whose intent is to affect the same targets or pathways. And then it's a race to the finish line. So you will have, where there used to be 1 or 2 drugs, like in the era of the taxanes, you might have 10 or 20, as in the era of PD-1, PD-L1 inhibitors. And I'm not sure what the solution to that is, because ultimately no one controls what a specific pharmaceutical firm can do with their ideas. But as investigators, I think part of our due diligence before we sign up to doing trials is to ask, is anyone already looking at that question, and how close are they to finishing it? Because to invest a lot of effort, and it takes a huge amount of effort to start a clinical trial in an institution, investing that effort to address a question that is en route to being answered in the next few months may not be the wisest thing.
Very good. Another question. What do you think the outlook is for the use of FDA-approved off-patent drugs for clinical trials if there isn't a pharmaceutical company to sponsor?
So, as I mentioned at the end, I really think many of the questions we need to ask in cancer trials and in other therapeutic areas, I would offer, are really questions about how best to use the tools we have, whether those are drugs, surgery, or radiation. And those will lie with what I call academic clinical trials groups. And a big problem in Canada is that there's no government investment in supporting the infrastructure to make that kind of work happen. Although it's not today's topic, certainly looking to see how quickly in the UK they pivoted when COVID-19 was on the scene to address questions about, does dexamethasone help? Does hydroxychloroquine help? Does heparin help? All of those questions that were kind of emerging from small studies, they have huge, it's actually the Department of Health that has invested in infrastructure to support networks of research, whether they're infectious disease, cancer, mental health, primary care. We don't have anything like that here. And I think the only way we can be in a place to move there is for particularly federal agencies to realize that providing the infrastructure and the wherewithal to do trials that aren't pharma driven is just part of what we should all be investing in and doing. Finding the funds to do a trial of a marketed drug or of radiation or of surgery, extremely difficult. And we can't rely on pharma to have all the questions that are worth answering.
Another question just came in. What do you think is the appropriate place for using surrogate outcomes, for example, PFS, in cancer clinical trials instead of overall survival?
So just to sort of back up a bit, along the way of cancer treatment, there are a number of things that can happen. Tumors can shrink, that's called response. There are objective response criteria. Tumors will grow, and the time to that event, or so-called progression-free survival or time to progression, is a measure that happens along the timeline towards whether a patient lives or dies. And frequently, increasingly frequently, investigators and pharmaceutical firms have decided to utilize these earlier endpoints. I won't call them surrogate, and I'll explain why. Earlier endpoints to seek approval of new compounds. And the problem is that in the vast majority of cases, these earlier endpoints are not good surrogates, proven surrogates of overall survival. So we are approving drugs based on something that we can measure on a scan that may bear no relationship to whether it improves quality of life or overall survival. And of course, those are the things, if you ask patients why they thought they would be getting treatment, it wouldn't be so my imaging won't progress so quickly. So that's a problem. That's a problem, and people have lots of excuses for why it's important. But I think, again, the investigative community and maybe the patient community needs to actually question that, because there's no doubt we'll get answers earlier, but whether those answers are worthy to find is something that remains an open question for many tumors, not all of them.
Good. You mentioned engaging patients. What mechanisms do you recommend to patients and their families to become involved other than through trial participation?
So the Canadian Cancer Trials Group has a long, like 25-year history of bringing patients in to every disease site committee as new trials are being discussed. So each committee has 2 representatives, patient representatives or family reps, and every decision-making committee. So in the clinical trials group, all proposals for large trials are weighed probably 3 times a year and ranked from the perspective of, is this going to have an impact on patients? Is it feasible? What's the science like? And part of the deliberations include patient reviews of every proposal, and they can weigh in on the ranking. So engaging patients in clinical research, I would say oversight, but also in trial discussions, I think is critical. It does require that you make a big effort to educate patients around what the clinical trial process is and allow them their voice to speak. And we're really lucky in the Canadian Cancer Trials Group to have our patient representative committee led by a woman named Judy Needham from Vancouver. And she's actually developed a training program for new volunteers to learn about clinical trials, to understand their role. It's now just part of how we do our work. A lot of therapeutic areas feel that patients are there to advocate for something, and that's not how we see it. We see them as there as providing an expert opinion about the research we're proposing, framed by their experience in cancer.
Thank you. Number of questions coming through now.
Yes,
One says, great talk. Would you like to comment on how utilizing biobanked cancer tissues in translational research has accelerated discovery via clinical trials?
So there are a number of examples I can give from our own trials group experience. So you will recall I talked about how we thought when we were moving into the targeted era, biomarkers would be important and easy. And the first part of that was right. The second part, not so easy. We tended to think of it the way we did hormone therapy in breast cancer. So if you have a lot of estrogen receptor on your breast tumor, you're going to be someone who benefits from hormone therapy. It didn't turn out to be that way for the first wave of drugs, the epidermal growth factor receptor inhibitors. The amount of receptor you had didn't seem to predict who was benefiting or not. And in the 2 trials I mentioned, one in colorectal cancer, one in lung cancer, both of those trials involved tissue collection. Both of them allowed us to investigate a number of putative biomarkers that we could then apply to the clinical data to see if they were in fact what mattered in determining a beneficial versus not beneficial outcome. So for the colorectal trial, it was looking at RAS wild type or RAS mutant status, and that turned out to split the population just perfectly. If you had a RAS wild type tumor, you were the ones who benefited from EGFR inhibition. If you had a mutant tumor, it didn't seem to do anything. And similarly, in the lung cancer side, EGFR mutations were what was differentiating the population. So doing the trial, even at the beginning, if you plan or think you know what the markers will be, but doing the trial in a sort of open-minded way, but collecting the tissue and allowing the tissue to be mined for information that you can marry back with the clinical data set, in those 2 examples really changed how we were selecting people for treatment.
Great. If prevention is a way forward, are there specific examples you see in clinical trials contributing to preventing cancer? Anything in the pipeline?
So the clinical trials group just has done a fairly modest amount of prevention studies. They were with hormone therapies to prevent breast cancer in high-risk women. Those trials were positive with a 2/3 reduction in the risk of breast cancer. But a lot of healthy people don't really want to take a medication to prevent a potential rare event in the future. And there's something to be learned from that, I guess. But the other places where prevention has been, aside from things like tobacco cessation, the other areas where a therapeutic intervention is preventative, of course, is in vaccination to prevent infection with viruses that cause cancer. And everyone, I'm hoping now, knows about HPV vaccination and hepatitis vaccination. HPV vaccination for cervical and other cancers has a huge potential for impact worldwide, still not disseminated out of the sort of high-income countries very well. But those are the examples where prevention's had a big deal. But the biggest single thing we could do to prevent cancer is to eliminate tobacco completely. 1/3 of all cancers, thousands and thousands of deaths in cardiovascular, chronic lung disease. And somehow we think tobacco's done. We've done that, been there, done that. Smoking rates are down, but it's still killing tens of thousands of Canadians a year.
What advice would you give to future researchers regarding how we can best use our creativity to develop interventions that are most likely to succeed?
Oh, wow. The everything question.
Mm-hmm.
I guess it would depend if you were clinical or not. I'll talk about future clinical researchers. I think part of how to use creativity is to be a team player and embed yourself early on in a team. Learn from your colleagues. Trying, and part of our problem in our university system and granting system is it matters whether you're first or last author. It shouldn't. Team science should be what we recognize and acknowledge. But early on, becoming part of a team, be a team player. Eventually your ideas and what you see happening will lead you to have questions. And as a credible team player, you'll then have a chance to actually have those questions addressed. So that's one approach. There is no recipe. There is no recipe for success in research. Not every idea will turn into a research study, but if you stop having the ideas, then none of them will. So I guess embedding yourself in the culture, the team undertaking clinical research, you will have a much better opportunity when you do have an idea to see it become successful.
That takes it to the end of our questions on Slido. Dr. Neymark?
Let me draw this lecture to a close by thanking the Gairdner Foundation for inviting the University of Manitoba to participate in the Canada Gairdner program every year. Great thank you to Elizabeth Eisenhauer for an excellent lecture. Would be a good model for some of our new researchers to pay attention to as a way of seeing research as a long game. And finally, to my colleagues, Doris Kuzma and Ed Krager, who form part of the Gairdner support group here that allows us to share the insights of distinguished Canadians. So once again, to Elizabeth Eisenhauer, thank you very much indeed for living up to your reputation in grand style.
Thank you.
And thank you all for joining the lecture. We'll now conclude, and Elizabeth Eisenhauer is, as I mentioned earlier, going to be speaking shortly to high school students from across Manitoba. And that's a program that comes out of the experience that Professor Krager's had for some years now. So thank you all very much indeed. Safe journey back to home, wherever that is.
Thank you.